Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Luchau.
Welcome to the Thinking Practitioner.
The Thinking Practitioner Podcast is proudly supported by ABMP, Associated Bodywork and Massage Professionals, the premier association for dedicated massage and bodywork practitioners like you. When you join ABMP, you're not just getting industry-leading liability insurance, you're gaining practical resources designed to support your career. From free top-tier continuing education and quick reference apps like Pocket Pathology and 5-Minute Muscles, ABMP equips you with the tools you need to succeed and grow your practice.
And ABMP is committed to elevating the profession with expert voices, fresh perspectives, and invaluable insights through continuing education courses, the ABMP podcast, and Massage and Bodywork magazine, featuring industry leaders like my co-host Till and myself. Thinking Practitioner listeners like you can get exclusive savings on ABMP membership at abmp.com/thinking. So join the best and expect more from your professional association. Good day, sir. How are you doing? Good to see you again.
Hello, Whitney. Good to see you too. I'm doing well. Yourself?
And I'm doing well today. We are getting in toward the holiday season here and looking forward to a little bit of slowing down of some things. But before we do that, we got some interesting things to chew on today. What are we talking about?
In this episode, Whitney and I take on one of manual therapy's most persistent and heated questions. Can we actually palpate the psoas muscle? If you followed this debate over the past decade or more, you know it's become much more than a question about just the anatomy. It's really a kind of proxy war in our field between pain science and movement educators who caution against making very specific anatomical claims or question some of our explanations for the traditional explanations for the effects of massage and bodywork on one hand, and on the other hand, manual therapy practitioners who've been working with the psoas for decades and think of it as both accessible and clinically meaningful. So at the Fascia Research Congress this year, Christopher DaPrato, a physical therapist from UCSF, presented a fascinating real-time MRI pilot study looking directly at what happens under our hands during attempted psoas palpation. And in this episode, Whitney and I break down what that study showed, what it didn't show, and what it might mean for practice. And stick around to the end because Christopher joined us briefly for a bonus segment to answer a couple of key questions about safety and tissue behavior. All right, let's get to it.
That sounds really interesting. You know, if people recall, we did do an episode on the psoas back on episode 25, I believe it was, pretty early on in the podcast about psoas treatment. So that might be one to go back and take a look at as well, take a listen to. But yeah, this seems like this isn't just a question about anatomy because there's been a pretty vigorous debate amongst all manual therapy fields, not just in our profession, but you see it across the board in numerous different professions. You sometimes have some more of the folks on kind of like the pain science movement focusing on things of, saying that a lot of the things that we've said we could do for years maybe not be happening, maybe are not happening, like in this instance, palpating some of these deep specific tissues. So this is an interesting study that they looked at here to see, was it possible to palpate the psoas muscle? Because other practitioners certainly been saying, a lot of manual therapy practitioners saying, well, we've been doing this for decades, a very long time, treating this and treating it successfully. So it was an interesting thing to address on. So
Rolfers. Rolfers. I trained as a Rolfer, worked as a Rolfer, taught at the Rolfer Institute. That's central. It's kind of foundational to our model. They were actually working with the psoas. And then you got other people, outspoken voices like Adam Meatkins, who's well regarded, although he can be kind of contentious, or Nir Eliyahu, the body mechanic, insisting, they say it's literally impossible to reach the psoas through the abdominal wall or the viscera. There's just too much tissue in the way, they say. But a lot of us say, hey, I feel something and my clients improve, so what's really happening?
Yeah. That's an interesting kind of debate, and I'd love to hear your take on this a little bit. This idea of saying, first of all, that we can't touch the muscle because there's other things in the way. The the reality, I think, around this is we really can't directly palpate any muscle in the body. We're always pressing through something to get there. And it seems like that's kind of like maybe the debate is a lot about where that line is getting drawn of what we can actually touch and get to there. So,
There's that old D&M critique that we're not actually touching anything other than skin,
yeah,
literally. And this was influencing this argument, but it's not the same one that they're saying, no, there's actually too much stuff to have any direct effect
yeah.
as well. Yeah.
So, well,
But this is
well,
like
let's
the
start with the
first
big, yeah,
time,
yeah,
this is the first time anyone's actually looked at it or, use an MRI real time to see what's happening under the hands.
yeah,
And
yeah.
let's just see what this debate's about.
Yeah, so this was a team at University of California, San Francisco, decided to look into this, and this is what was presented. You said was presented at the conference there. So, kind of what was the sort of driving ideas behind getting this study started?
I'm gonna speculate some. Again, I saw the presentation, read the study, but I think not only is the debate interesting, but the psoas is thought to be significant, and in discussions of hip biomechanics and
Mhm.
low back pain is thought to be a key player there.
Yeah, and so kind of looking into this, we've all heard a good bit about the psoas being related to low back pain and things like that. So why? I mean, kind of why does that matter so much?
Well, let's talk about what they actually did. The
Yeah.
real-time MRI setup was fascinating. You could actually see the tissues moving as pressure was applied. You could actually see they use both a hand and a probe to see if the psoas could be touched. I'm not going to
Mhm.
give away too much, but they basically compared two conditions. I'm kind of getting ahead into your territory here a little bit.
Yeah.
They compared two conditions: the manual self palpation and this tool, the Psorite tool. There's a few of those. It turns out that I didn't realize as I looked into it. There's a few of these tools that people can lie on that are thought to can work on the psoas. Not exactly foam rolling; it's more of projection. But it's basically this one's basically a molded wedge meant to approximate deep anterior hip pressure. And they
Yeah.
chose. This is interesting too. They chose participants with two very different BMIs to look at how body composition, that's basically body size to height ratio, how
Mhm.
body composition affects access. They chose somebody with an above average BMI and a below average BMI.
Yeah. And this was interesting, the idea of self-palpation. They were having individuals try to palpate themselves. I'm just curious, did he mention it all in the presentation there, how they
Yeah.
train people to find this on themselves?
Well, they gave him some instructions and they did self palpation because they couldn't have a therapist in the MRI with them.
Exactly. Yeah.
And they wanted a control, or they wanted somebody to compare to someone not using their own hands. And so that was the tool.
Hmm. Getting to that, and I believe in the study they mentioned they were trying to guide them toward the L4, L5 level. So that's, if you, again, sort of recalling our anatomy of the iliopsoas, that's, the area very close to its attachment site on the lumbar spine, as opposed to, for example, palpating it where it comes more superficial across the top of the iliac crest. Did he happen to mention in there why they chose going to that location?
No, I don't recall that. If you did, I don't
Mm.
recall it.
Yeah.
But you're right. It is really deep there. It's behind a lot of the viscera,
Yeah.
and it's very far down, lower down in
Hmm.
the abdominal bowl there.
Yeah.
But I'll go ahead and share one of those headline findings. The palpation with both the hands and the tool in both subjects reached to within 7 to 11 millimeters of the psoas. That's like less than half an inch in both cases. So
Hmm.
you could see the actual tissues getting displaced and the tip of the subject's fingers or the tool itself within 7 millimeters sometimes of the psoas.
Yeah. So I'm trying to visualize this tool for a second. So is this something they were prone or supine when this tool was
Prone,
applied?
the tool, yeah, the
Yeah.
tool, they were prone lying on the tool. It's like a wedge. They're
Okay.
prone lying on this wedge in the anterior hip.
And so they are just kind of like, um, it's sort of their body weight that gets it to just work its way down into the location there. Is that sort of the idea?
Body weight and their relaxation.
Yeah.
So you lie on this tool. I guess I haven't actually tried it. Lie on
Yeah.
this tool and relax. And although I've heard people say that they've got benefit from it.
So one other thing that struck me in reading this, and you mentioned a moment ago, the tool and the self palpation were getting within a relatively close distance. I think they said something like 9 or 10 millimeters, which is about a half an inch for those not on the metric system there.
7 to 11 millimeters, whatever. Yeah, right.
Yeah. Okay. So so if it's not touching, if it's 7 millimeters away, does that mean that there's still other stuff in between where it appeared the fingers were with the MRI and the actual muscle itself? If it was not directly making contact, like, is that still like internal abdominal organs, or, what's in that gap in that
What's in that gap?
Yeah.
Well, there's skin,
Mm-hmm.
there's abdominal wall,
Mm-hmm.
and there'd be the fascial covering of the psoas. But I think the presumption was the viscera had moved out of the way. He had some clearer comments about this, but in his view, because one of the critiques of working this is you got to poke through viscera, and viscera
Right.
is soft.
Yeah.
So it was displacing, but not, he said, in alarming ways. There was some compression against the psoas, but not pushed aside dangerously and not being pinned in ways that he considered dangerous. Well, in the image, 7 millimeters is pretty thin. If we just look at 7 to 11 millimeters, we're right there. We are literally as close as you could get to the psoas in
Yeah.
instances. And again, his takeaway was that no, there's all kinds of visceral movement anyway, normally, and including in normal postural changes or leaning against something elsewhere or lying in bed, and that this is well within that range of things that usually happen there.
Yeah. Interesting. I think also in there he mentioned something about shape changes with the iliopsoas was that the result of the pressure being applied in that region there, or what were the shape changes about?
That's significant because the question, can we touch it, is one thing, but are we actually influencing it is another.
Mm-hmm.
And at least, again, the MRI is going to show shape. And so the MRI did show a shape change. You could see the psoas deflecting around the point of contact in a way. So we are actually moving or changing its shape, rather causing it to deflect or bend around the point of contact.
So this is interesting to me, this idea of the shape change. So the psoas was responding to the approximation of pressure by changing its shape. Do we know, for example, that this happens with, do other muscles do this, or was this something unique to that? Do you have any idea?
Was there a control on another muscle to see what it looks like when palpated in an MRI?
Yeah.
No, not in this study, and I don't know of studies, but I think we can presume. If we just look at our bicep and poke our bicep, it deflects in a way that was similar to what we saw that psoas deflecting on his MRIs.
Yeah.
So it's obviously got an obvious dent in it where I'm poking with my fingers, and I can change its angle and flatten it some, or actually bend it around my finger.
Uh-huh.
But I think it's pretty safe I don't think anybody's saying we're not actually changing the shape of muscles with our touch.
Yeah.
We can actually literally see that with something like the bicep. In this case, now we can see it with the psoas too.
Right. So then, kind of taking it back to a clinical perspective, if a palpation can get that close to the iliopsoas and there's some kind of response in the muscle, which we saw through that particular MRI image, kind of what does that tell us clinically? What does that mean or imply about the attempts to treat it, angle of pressure, depth, etc.? Any thoughts on?
Yeah, there's a discussion about what's clinically useful, but let's just stick with the physics for a second. Are there implications about angle, depth, and pressure? It makes me trust my hands more to see images that look like what I'm feeling as a practitioner. For example, just my own subjective sense. And we all know that it's a sensitive zone, and that the pressure, you don't need a lot of pressure, you need a lot of patience in this case. And it's not about scraping around in there and releasing something in the abdomen.
Yeah.
Most of our training in my method is about taking care and a very gentle touch. So it doesn't change much of that for me. It doesn't say, okay, now we can go in there raking around, because that word is used to describe sometimes what happens with the psoas in some of the more traditional direct methods.
Yeah.
But we're
Right.
not raking the psoas. We're still gentle, but it's still the angles we traditionally use, the depth we're traditionally using, the
Yeah.
pressure seems to be appropriate to me still based on what I've seen there.
Yeah. Well, I'd like to hear kind of maybe your opinion. What do you think after reading this? If there's the kind of big old, excuse me, bigger clinical question around this, if we can reach it, if we can do things, if we can touch it and see responses on there, what does that kind of tell us? Does that change the way you work or think about working it, or anything like that?
Well, it it does and doesn't. Like I said, it makes me trust my hands more, perhaps, because I can now have an image to go with that. But it's mechanisms. It's not telling us much about mechanisms. They're probably neuromuscular mechanisms, probably reflexes, they're probably refining proprioception. Now I can feel my back. Maybe there's some activation. Maybe there's some greater relaxation or differentiation possible. All those things,
Yeah.
probably some descending modulation, maybe greater engagement. All these mechanisms we think about and know are probably at work there.
Mhm.
And the fact that it's physically similar, the findings are physically similar with the tool and the hand are interesting too. But the hand was a bit more significant. The tool did have an effect, but it's again, its physical findings were not as significant as someone palpating their own psoas. Maybe because they could be more precise, maybe because
Yeah.
they could tune their pressure more to what was actually comfortable for them.
Yeah.
But there was a greater visual effect with the hand, with the so right, although they were both pretty similar.
Yeah, I'm curious to did they mention at all in the midst of that presentation about the training people to palpate the psoas? Like, I'm assuming that they had a practitioner who was skilled in getting close to that region and doing what they said was locating it to make people have a sense of this is what it should feel like when you get on this thing. Do you know if
Uh,
they did something like that?
there were definitely instructions, but I don't recall the training they were given. That
Yeah,
was probably in the study. Yeah.
yeah. Well, this is this was pretty interesting. I noticed like in the end of it, he said that the study kind of challenged the assumption that the psoas is unreachable. I mean, just speaking for me personally, I've always had a problem with that idea that it's unreachable because if you can feel, get close in on that area, have a person respond with the sensation of feeling touch sensations in that area, and then, for example, engage the muscle in resisted contraction, having the person attempt to lift their thigh up, you clearly feel something pop up underneath your fingertips in many instances. And to me, it's like, well, what is that if it isn't the psoas that's doing that? The only thing that's different there is engaging that muscle in a contraction. It seems pretty clear that that's what's popping up underneath your fingertips. So um, I'd have to say, like I don't like to put myself in one camp versus another, but I'm certainly more inclined toward the idea of like this is palpable. Just as if any other tissue is. Yeah, you're always pressing through other things to get there, but you can get a response from getting pretty darn close to touching that muscle, I think.
Well, yeah, I'm thinking of myself in both these camps as well. And I'm into myth busting and having clear evidence for the things we think we're doing.
Mhm.
I'm also into honoring the traditions. And then I'm mostly into like trusting my hands. When I'm in there and I feel something and someone moves their hip and I feel that something bulge out at me and push at me, it's
Mhm.
the idea that's the size and it's contracting. It sounds pretty compelling. It's a pretty compelling explanation. So
Yeah.
this in some ways is validating what I feel, or it's giving some hope. Maybe we'll see. We haven't heard from the critics yet. I don't know what Adam Meekins would say.
Mhm.
That would be curious to know. The critics of this idea that we can touch the psoas, I don't know how they would respond to this, but it's some pretty clear evidence that we can actually
Yeah.
influence its shape and deflect it and flatten it with our touch.
Yeah. The thing that I'm still kind of on the fence about is like I still feel pretty strongly that we can apply pressure that gives indirect pressure onto that particular muscle. The thing that I still have some concerns about is it a good idea? Because I have some doubts about whether or not we can really get all of the internal viscera to just squeeze out of the way. And that, that's why I was asking about that 7 to 10 millimeter distance there. What is in that distance between where it appeared the fingers were and the muscle itself? I mean, that still may be viscera that you're squeezing and pinning against the iliopsoas. So yeah, you feel the muscle pull up against you, but you're feeling other things in there as well. And didn't
Most of the
seem
side
like,
of the way, there probably is
yeah,
some in there. Certainly mesentery. We're not going to get everything off to the side.
yeah,
But, and there's, I mean, I made this case in my book, in a couple chapters about the psoas in there, that there's, I stated there are very few cases, documented cases of harm being done through manual therapy to people with the psoas. Of course, that got people to send me a couple. There are actual documented cases of people being hurt by manual therapists being too
yeah,
aggressive on their psoas. So it's certainly we need to be careful.
yeah,
That's like I said, that's the main consideration here, because there probably is some visceral tissue there between our fingers and the psoas when we're working there, and visceral tissue is soft, so we need to work in a soft way.
yeah. And the thing that I didn't see mentioned in the study, I would love to have a chance to ask him about this, is that, and again, kind of back to what you're saying, this is definitely not something that is a likely and frequent occurrence, but I still think uh, potential harm or problem with vascular structures, especially the external iliac artery and its proximity to the psoas, which you,
Sure.
again, won't necessarily feel if you're pressing on it. And there,
Well, you can often feel the aorta on many people right
yeah,
there next to it, thumping away.
yeah,
And aortal aneurysms are something to keep in mind. It can get blowouts and bulges, and we don't need to be poking the aorta. A
yeah,
little higher up, you get into all of the vasculature that goes out to the kidneys, and it's substantial. They filter a lot of blood.
yeah,
The raking idea is really the wrong one. We don't want to be plowing through all that vasculature. And the ureters run down the face of the psoas, and you don't want to be tangling them up. The visceral people have been saying that for years. Be gentle with the face of the psoas because that's where the ureters are, and
yeah,
you don't want to pull them anywhere they don't want to be either.
yeah. So I'm sort of based on this. I'm curious to hear your thoughts on this as well. They've talked about, at least in this study, of attempting to palpate it near its proximal origin site on the lumbar spine. What do you think about like getting much farther along the distance of the muscle, like closer to where it's blending with the iliacus and coming across the top of the pelvic bowl, where it seems far more superficial and far less likely to be problematic?
Like you're asking, do I think that's a better place to work it or say?
Yeah. Yeah.
It's actually more sensitive there. People are ticklish there, and you got all kinds of bursa and big old,
Right.
femoral nerves and arteries right there anyway.
Yeah.
And so, yeah, I'll do some work there, especially if there's like a pinching or an impinging feel
Yeah.
related to hip flexion or internal rotation. I'll often pay some attention to that zone, but there's mostly about getting the tissues to slide around and slide out of the way when the bone's moving.
Yeah.
I think there, I've never tested this. I should do this. I should like work somebody in their hip and work on their other side in their lumbars, so as and see, which one makes a bigger difference for back pain. But it's a pretty clear factor in, at least in the improvement of people's back pain during the session and as they get up off the table.
Mm-hmm.
You can help so many people's low back pain by working with their psoas in the lumbars. I haven't tried that at the front of the hip. That might be interesting.
Yeah. Right. And so, well, then, that kind of takes us kind of back to sort of key clinical takeaways here. What sort of, well, when you heard this presentation live and also in sort of reading this again, like what were your big takeaways from that?
Well, again, we can trust our hands if we are working psoas and feeling it. Yeah, but there's some images of things doing just that. We probably aren't imagining it, like some of the critics have said, or probably not delusional. It doesn't clear up like what are the mechanisms involved, but we've done a lot of thinking and work about that. We may be refining proprioception as much as freeing up the fascia. There may be direct tissue effects, but the neurological ones are at least as significant, if not more.
Yeah.
And it's still a sensitive zone. We're not, again, in Dr. DaPrato's estimation, we're not dangerously displacing or impinging viscera, but we're working right there with viscera, nerve, lymphatic vessels, all that. We need to be gentle and careful in the belly for sure.
Yeah. I think for me, after reading this and just sort of echoing what you said there, if there's any key takeaway, it's that the quality of that touch matters a whole lot, I think. And so what you're saying there, there was a phrase that a friend of mine mentioned years ago that I just always loved. He said, like, I work constantly with ruthless compassion. And I think that whole mindset of any time that you're doing something that is that potentially deep and it's an unusual sensation to have your abdomen, penetrated that deeply by manual, techniques and things like that. That sense of safety, context, and gentleness to your touch is going to be absolutely critical.
That's right. That's a lot of what we're transmitting with our touch.
Yeah.
Thank you for that.
And keep those fingernails short.
You're right. And stay in contact with your client. Talk to them.
Right. So
I did get Dr. DaPrato on the line very briefly. He wasn't able to make it for our discussion, but he gave me his opinion on a couple of the questions that we left hanging. Why did he choose that level? And what's his opinion on the abdominal displacement and safety concerns? And he had some good things to say. Let's hear from him.
Hello, hello. Can you hear me?
Hello, yes.
Feel free to ask any questions that you have right now.
Well, here's one. Why did you pick L4, L5?
So easy to locate because you can find the L3-4 interspace based on the iliac crest pretty easily, and then palpate down from there. And it seems to be an area that is easily to palpate above the ilioinguinal ligament on most humans, the way the pelvis is oriented. So because of the space to the pelvis, the ease of palpation and proximity, that's why we chose that.
Great, that's pretty clear. And then my memory from your presentation was that your opinion was that you didn't think there was like dangerous abdominal compression or displacement, that it seemed kind of within the range of normal. Is that accurate?
Yeah, I think if you clear your precautions in terms of the patient populations you have, and they don't have irritable bowel or bladder issues or, inflamed uterus or ovaries, things that are in that region that can be, irritable. Even endometriosis could be like something that could be a problem for some individuals. But as long as you screen through that, it's pretty safe. And I think, like you could see on the MRI, those visceral contents just slide so much easier than we give them credit for.
And that's happening when we're palpating or working there too.
Yeah, exactly. So, as long as you're clearing the inflammatory process that might be going on in that area, I think it's pretty safe and pretty effective. And again, in our 2 patients, no adverse events were recorded except for, being in an MRI for 20 minutes while you're getting pressed on at different pressures. So it's just one of those things that's not comfortable to do in an MRI, but in a clinical setting, it should only take 2 to 4 minutes. So it shouldn't be that long.
No. Well, it was such an interesting study. You did such a great job with the study and then with your presentation, really compelling.
I mean, it was simple, but effective, right? It was a very easy study to do, but you have to make sure you run the steps and try to be as consistent between each subject as possible.
Thanks a lot. Bye for now.
You too. Bye-bye.
We'll link to this study in the show notes. It has some of these images. You can actually go there and see it for yourself. And thanks to Dr. DaPrato for being able to join us there briefly. Sorry we didn't have him for the whole call, but I'm glad he got to weigh in on those questions. Whitney, how do you want to wrap it up?
Indeed, yeah. This was an interesting look at the psoas, and I think I would hope that we'll get some additional, that this maybe be a seed planted for some other additional explorations of that can look at some of these clinical elements as well as some of the other deeper anatomical elements about accessing the muscle. But it was a fascinating first-time exploration of this that I have seen in any of the research literature. So eager to hear that coming out there. So with that in mind, we would like to thank Books of Discovery, who has been a part of the massage therapy and bodywork world for over 25 years. Nearly 3,000 schools around the globe teach with their textbooks, e-textbooks, and digital resources. And Books of Discovery likes to say that learning adventures start here, and they see that same spirit here on the Thinking Practitioner podcast and are proud to support our work, knowing that we share the mission to bring the massage and bodywork community thought-provoking and enlivening content that enhances our profession.
And this is kind of cool. Instructors of manual therapy education programs can request complimentary copies of their impressive textbooks to review for use in their programs, listeners like you can explore their collection of learning resources for anatomy, pathology, kinesiology, physiology, ethics, and business mastery at booksofdiscovery.com, where listeners to our podcast save 15% by entering thinking at checkout.
And thanks to all of our listeners and to our sponsors, you can stop by our sites for the video show notes, transcripts, and any extras. You can find that over on my site at academyofclinicalmassage.com. And Till, where can they find that for you?
Advanced-trainings.com is our website where we post all those things too. And we want to hear from you, listeners, of your ideas about the episode, your input about other topics or guests we could have. Just email us at info@thethinkingpractitioner.com or look for us each on social media and on YouTube. I am at Till Luchau. Whitney, where can people find you?
Also under my name on social media, Whitney Lowe. Thanks again, everybody, for being here. We really appreciate it. If you could take just a few moments and rate us on Spotify or Apple Podcasts, as it does help other people find the show. So please just take a few seconds to do that. And thanks again so much for listening. And we'll look forward to sharing some other things with you in the future. So if you will also share the word, tell a friend, and we'll see you in the next episode.
Thanks, Whitney. See you later.
All right. Sounds good. See you.